Good morning. Thanks, Nishant, for doing this. I wish I'd published more in this area. I really have not done enough. We've been more consumers of imaging in our VT ablation workflows than we have been publishing, although we have a lot of experience with it now, and we'll be have some data hopefully coming out soon. See if I can advance my slides here. So I love to bring up this slide in any VT talk. You know, we lost really two legends of VT in the past couple of years. Dr. Wellens just passed away, I know, recently, and that's been all over Twitter. But his partner in teaching, Dr. Josephson, really led the way in much of our understanding of the substrate for ventricular tachycardia. And, you know, we want to connect how we use imaging and mapping systems to what was really identified at the macroscopic level in the operating room by Dr. Josephson 40 plus years ago. And it really began with these aneurysm resections for management of VT, but with the interesting finding that just resecting the aneurysm alone was insufficient for controlling VT. And it was from there that they did extensive work to really identify the subendocardial disease with fibrosis interrupting these sort of bridges of dissociated myocytes that could create the substrate for reentry at the subendocardial level. And this is a microscopic view, but in reality, it's a very complex three-dimensional architecture. And this really had me and, you know, certainly many others, and, you know, I think in particular the Bordeaux group and Saman Nazarian at Penn, formerly at Hopkins, and Frank Bogan, among others, really leading the charge in terms of using imaging to begin to discern those different areas of electrophysiologically vulnerable or rhythmogenically vulnerable areas of scar. So it's a really complex 3D problem to solve. How do we see these things? There are mapping tools, there's imaging, there's a lot of very nice work that's been done with mapping and some of the difficulties in mapping, particularly by Rod Tung and his group, and Shiv and the group at UCLA. How do we hit the target? You know, are there better anatomic approaches that can be identified? Will imaging be helpful for pre-planning? Okay. The classical approach, this is the way I was trained, certainly by my mentors in Boston, to address VT, and this was, you know, really before imaging. I was a fellow in 2009 to 2011 for EP at least. And, you know, we identify the scar by the standard definition of less than 1.5 millivolts, and that's a moving target these days with high density mapping and smaller electrodes. We found an exit region if we had a 12-lead of VT either from induction at the time of the procedure, from an ECG, perhaps in the emergency department. We would then proceed with pace mapping, initiate VT in the area of interest with the catheters positioned strategically in the area of interest, entrain briefly if we could, map if we could, if they were stable, but that's rare. Only about 20% of VTs are mappable. Most of them fall on the right side of that column, the unstable VTs. And then we would ablate, you know, in perhaps just a small line through that circuit. But, you know, it turns out, you know, the outcomes may not be any better with induction. I mean, it's really a probabilistic approach to determining an endpoint, and it doesn't necessarily mean you're going to be any more successful. And so perhaps we'd be better off just identifying substrate and targeting that. This is a nice work from Baruezo in 48 patients randomized to induction or not, a mix of cardiomyopathies. And basically, if you look at the Kaplan-Meier curves, there's really no difference between substrate ablation first versus induction first. They do about the same. And so it sets up this question there you go, of how best to ablate substrate. Do we do, you know, precision warfare? Are we kind of like SEAL Team 6, assassinating, you know, kind of one little target with limited linear ablation? And that's certainly one approach. It's an approach that I became familiar with as a fellow. Or do we just homogenize scar? Neither approach is exactly wrong, although I think we've moved to the right of that, certainly. And you know, the 5 years after I got out of fellowship at Loyola with Dave Wilbur, really kind of pushed me into the substrate approach. But I was still interested in perhaps being somewhat more precise and using physiology at least to guide our decisions about where to ablate. That is, what are the vulnerable areas of scar, okay? And I know there's a lot of interest in using various mapping approaches. Can we use imaging perhaps to do that? High density mapping is certainly a powerful approach, but it's confusing. You know, I don't know that there's a single standard. This is a swine infarct model done in the Lada Andrews lab when he was in Boston. I know he's in Cleveland now, with Corey Chabran, who's now relocated to Penn. They're pretty lucky to have Corey. And this is a dense scar mapped with a linear ablation catheter, basically. This looks like the scar that most of us grew up seeing as we learned as fellows. And then you take the same infarct with this multi-electrode model or a mapping system, you see much more heterogeneity in the scar. You see more scar architecture where you have these little preserved areas of voltage that perhaps may indicate a channel, a conduction channel. Okay, and so, you know, what again is the best approach? And I'm not here to answer that question. The question is whether or not imaging could be helpful. And with high density mapping and multiple electrode systems, it gets even more confusing. What's the best way of doing it? There's a list here on the right of multiple high density electrode catheters. You know, we all have our favorites. I know Rod Tong likes the Livewire Duodeca. I like the Grid. Some people like the Pentaray. There may be other catheters emerging. And I know then Rod has done a very nice job. Dr. Tong has done a very nice job with the Orion catheter. So lots of different approaches, but perhaps we could standardize it more with imaging. Thank you. The approach to mapping again is influenced by wavefronts. You know, it's very difficult to identify a rhythmogenic substrate if you just map in one rhythm sometimes. And Rod really drove this point home in this very beautiful paper. This is one of my favorite papers that I encourage all fellows at least to go and look at, where if you look at this QRS and we annotate late potentials, which are indicators of slow conduction into a scarred myocardium, you can then measure these yellow lines to indicate timing. And the lateness of that sort of is a surrogate for slow conduction into that area. Okay, and you can then create a map, what we call an activation map, indicating timing. And so what Dr. Tong has done in this is show timing. The later signals are purple, the earlier signals are red. And in sinus rhythm, down here by the apex of the left ventricle, you're earliest. And then there's this migration of a wavefront upwards up the septum to this area where he ablated, and there's this compression or slowing where the colors begin to come together. If you change the wavefront, instead of sinus rhythm, now lateral LV pacing, it changes the distribution of colors, it changes the distribution of late potentials and conduction into that area. And so this is really confusing again. It's just, I don't know when I do a case what rhythm is best, and we've been, just this week, we've done 2 large intrathecal apical MIVTs. We've mapped an LV pacing. We've mapped with sinus rhythm. We've mapped with RV pacing. We've done 3 different maps before we've ever turned the ablation catheter on, just to look at isochrones. Okay, so would we be better off with imaging? And we did do pre-procedure imaging, and we're very interested in correlating those things. But let's see if I can advance. There we go. Perhaps one solution is to use a multi-electrode catheter like this that can then, independent of wavefront, look across splines, between splines, and that may help solve the problem, but that could be even confusing. If we look at this grid signal now, this is what we call lavas on late potentials. Lavas are those local and abnormal ventricular activities that were described by the Bordeaux group about 10 years ago. This is your sinus rhythm QRS complex. You see these signals that are well after the sinus rhythm QRS complex. We then pace from that spot, and we see 2 different QRSs. You see this first one, and then there's a subtle shift. These last 2 QRS complexes are different than this. And we see variable exit. These signals kind of redistribute. You can see that with a different exit, the signals take on a different morphology. Maybe we can identify scar differently with MRI. Delayed enhancement. I know the Northwestern group a long time ago, I think in the early 2000s, really described the utility of late gadolinium enhancement to describe scar. And there are different scar patterns for different disease patterns. In normal myocardium, there's no delayed enhancement. In this instance, with coronary disease and prior MI, there's a subendocardial distribution of scar that you can see here. And then in DCMs or sarcoids, you can see this patchy mid-wall stuff or patchy septal and basal LV scarring. And this is much more challenging to map and maybe even elude our normal contact-based mapping approach. So can imaging be helpful? This is a patient we took care of at Loyola with Dr. Wilbur some years ago when I was still at Loyola, where we did not have imaging. And this is a very elegantly mapped by Dr. Wilbur with a non-ischemic cardiomyopathy and had mapped with activation mapping focal breakthrough on the endocardium and on the epicardium here and here. See this red spot, kind of like X marks the spot? That's the focal breakthrough of a mid-myocardial arrhythmia. There's normal voltage on the endocardium and some scarring present on the epicardium. And with RF, at the earliest sites, it would slow and terminate, but required ablation on the other side. And the question then becomes, and this really, made me wonder, and Dr. Wilbur certainly, kind of pushed us in this direction, begin to consider imaging. In this instance, this was a sarcoid type of patient where you see this scarring that can be mid-myocardial and certainly not visible to an endocardial mapping approach. And that's, it tends to be patchy. And MR certainly can correlate with VT inducibility and non-ischemic cardiomyopathies. This is now old data from Salman Nazarian, who's an incredibly talented investigator now at Penn, looking at MR inducibility and basically, with scar distribution involving just sort of the mid-myocardium in a sense, you have a higher instance of inducibility at the time of VT study. In infarct models, this is 48 patients with coronary disease referred for EP study, and infarct surface area was more predictive than ejection fraction for inducibility. And in follow-up to that, Andrew Yan and the Brigham group, imaging group, when I was still fellow, looked at scar heterogeneity as a marker of induction. And what they basically looked at was the grayscale of these of the late enhancement, and just divided into a standard distribution with gray zone, which is area of with the standard deviation cutoff of 10 to 28. The core was greater than 28, and the gray plus core is any area with greater than 10. So this was dense scar basically, and kind of less dense scar, if you will. And the question was, if that ratio shifts to less dense scar, are they more arrhythmogenic? And indeed, they found that with peri-infarct scar kind of greater than or equal to the median distribution, these people tended to have more inducibility. They had more arrhythmogenesis. Okay, so the idea that getting back to that heterogeneity, that very first slide I showed, showing a scar that was heterogeneous with collagen and myocytes distributed. When there's that enough heterogeneity in that scar that we can image, they have a higher propensity for developing VT. They're more prone to VT. This is a patient that drives home this point where ejection and the limitations of ejection fraction for predicting inducibility. This is a 64-year-old man with an inferior MI, lots of non-sustained VT. Normal ejection fraction had this inferior MI visible on an MR, had peri-infarct scar volume of 27%, and died of sudden death outside the hospital 11 months post-infarct. Did not have a defibrillator. Okay. And so, in follow-up to that, an EP group then looked at MR heterogeneity, tissue heterogeneity, and scar, and wondered about predicting scar channels. This is a patient with an anterior septal MI and VT. And this is a patient with an intraseptal MI without VT, and the blue represents areas of some heterogeneity, and there's basically more of it in the patient with VT. And they then went on to look at, and this is difficult, and I think one of the questions is the applicability of these approaches with MR in the general population. And I think, you know, the overarching goal of all of us who ablate VT in centers like MUSC and Northwestern and Chicago is to make these procedures more accessible, not less accessible. And with MR, though this is very beautiful work, it's very difficult to do. And so it opens the question of whether or not CT imaging could be more helpful. We'll talk about that in a minute, but I want to drive home this point. This is the mitral annulus, dense scar here, and you see this little bridge here. And could this be a site for VT erythrogenesis? Can it predict a mid-isthmus site? This is a patient without VT, and you see basically more confluent red areas than these interrupted red areas that may indicate a lack of a channel. And indeed, this is a little area of scar. They've taken the voltage calipers way down from 0.2 to 0.21, and there's this little area of preserved voltage, and it correlates fairly nicely with the little bridge area. And they showed that indeed that area was consistent with area of slow conduction, what looks like an entrance area, or not quite an entrance, but early area for activation. Why do we fail? This is a slide I think most trainees who've come out of the Brigham have. This is a patient that Dr. Stevenson took care of when he was there, who underwent ablation and then ultimately transplantation. The heart was explanted, and this was a patient who continued to have VT, and these are the ablation lesions here. And there was presumably an area of reentry involving this sort of mid-myocardial scar here. And so can imaging be helpful? This is a patient that was sent to me with recurrent slow VT after 2 prior ablations, had a remote inferior wall MI, a remote bypass operation, so couldn't go epicardial, at least not easily. And the backside of the heart is very difficult to do surgically. There is no occlusion of the right corner and a vein graft to a right PDA. This is, there it is. This is our VT. It's very, very slow, right around 600 milliseconds, with this kind of left bundle, unusual axis that we presumed was inferior, coming from some area near the septum. We saw with our CS activation, you had this AV dissociation here. Here's our RV catheter. The RV catheter was sitting kind of mid-septum and isn't exactly early, but then you see this signal kind of along the mitral annulus, which was intriguing to us, and the proximal CS almost looked like it was mid-diastolic. And the question was, could imaging be helpful here? We didn't have imaging at this point. We ablated like everybody else had done from the inferior wall in this dense scar area and slowed and terminated VT almost immediately. We felt great about ourselves, but we wondered what the big deal was. The prior group had ablated and terminated VT there, so we didn't feel too good about it because we induced VT again. And we went then down to the coronary sinus, into the coronary sinus, because we'd seen those very intriguing signals on this catheter. We went down here to the MCV and found this wonderful signal that was about 114 milliseconds pre-QRS entrained. Sorry, this is a lousy entrainment. It's a good entrainment, but a lousy slide because it's hard to project, but it's the best I could do. But basically, we had a concealed entrainment with a stim to QRS that equaled the electrogram to QRS, and it was spot on. And we came on RF and slowed and terminated almost immediately in that location. But I would have loved to have seen, this anatomy sooner. And, the question for me was whether or not imaging could have guided us to this position before messing around over here in the left ventricle, which had been tried and failed twice before. So this brings us to this InHeart, and I know there's some other emerging technologies, but InHeart is a group out of Bordeaux. This is Piaget and Hubert Cochet, and the music consortium of which we and I know Ushitedra and several other groups in the US are part. And it provides some scar imaging beforehand, okay, including all the chambers, the epicardium, the coronary sinus, which would have been relevant in the last case, the location of the phrenic nerve, which I'll show in a few slides in another case, and how that was helpful to us. The music consortium includes many centers. We actually started, my first exposure to this was at the very tail end of my time at Loyola, thanks to Dr. Wilbur. I know the Penn group is working on it, and Dr. Santangeli and I are talking about one project with that. There is a lot of collaboration here. These slides are compliments of Piaget and Hubert Cochet, so I've left the lyric stamp up there. But what they basically asked is, what do we need to do these procedures safely, and can imaging be helpful? I know there's some debate about this. I had a really nice discussion with one of my heroes, Dr. Callens at Penn, who was sort of he's much more of a skeptic given issues of registration, but I think we can learn something maybe. Accurate anatomy of the cardiac chambers is of course necessary. We need anatomical landmarks for optimal registration. So can we take the CT image and can we merge it with our 3D mapping system and perform an ablation where there's high spatial fidelity between the data on the CT and the data from the mapping system in real time? Can we identify structures at risk during epicardial ablation, primarily the coronary arteries and the phrenic nerve? Can we then localize the structural substrate? So we know where the scar is, but can we find the target-rich areas of scar? Okay, can we become more like SEAL Team 6 rather than kind of light infantry invading a scar and just pounding everything to oblivion and shock and awe? Can we identify structural substrate heterogeneity? Okay, and the software is pretty sophisticated. It builds all this entire model. They do it very quickly. I mean, sometimes we have sent cases in the morning for an afternoon case, and they'll have the model back to us in 2 to 3 hours. And it's really rather remarkable. The anatomy always comes back with the left atrium and the aorta, the LV endocardium, the LV epicardium, the RV epicardium, coronary sinus. They identify thrombus, and on multiple occasions, I've actually gotten notification from the group in Bordeaux that my patient heading for VT ablation later in the day has a thrombus that was missed on an echo. And it's before even I get a read from our radiology group here. And we've, on numerous occasions, probably once a month, we'll pull the patient off or cancel the procedure based on the identification of that thrombus. And so this is the model that is built. And you get this anatomy that you can then integrate with the mapping system. It's helpful to place catheters and venous structures. That's often our workflow, is to use coronary veins, and we can create a pretty dense map. If we get more branches, all the better, because it makes for easier registration. And that's relevant for avoiding coronary injury, particularly in epicardial procedures and the phrenic nerve. And so here's your great cardiac vein extending out to the AID, and a catheter there can certainly help guide our registration and avoid injuring large diagonal vessels or obtuse marginal vessels in particular, or the phrenic nerve you see there. In RV ventricular disease, we did an ARVD just last week. The CT was actually not available, which is frustrating. It had been done, but was not available just due to some informatics issues on our end. But we still, we did it the traditional way, but I sure missed it because it's nice to be able to see the RV marginal branches coming off this right coronary artery here, which it runs along the AV groove and the tricuspid valve and sends those branches out. Visualizing fat can be helpful. Here's some scar there. And then visualizing the substrate. Okay. And what I like about CT compared to MR, and we're lucky here at MUSC, the radiology group here actually came from the Brigham, and had a lot to do with developing late iodine enhancements, and has really given nice images. And what I like about it is it's more easily reproducible and more accessible than MR is, at least in our center, and probably in most centers.